The good thing about Steve is he came from the community side. Steve was a director of Mentor in North Carolina and a director of Res Care in North Carolina, providing services to people with intellectual and developmental disabilities, and he has a good knowledge of that from his past and continues to obviously care and know about those services. You know, when you get these resumes and you want to talk about people, they often are flat, they don't mean a lot. So let me tell you a couple other things. One is that Steve is a very passionate and committed guy. I know that from when he was providing services and having a chance to work with him sort of on the other side before he went to state government, that his commitment to people is absolutely real and what he wants to do to support individuals, and he understands that. One of the things that he'll never tell you, but is that Steve tries to figure out from people how to make our system different. I know at a couple of DD Council meetings, he's been there till midnight almost talking to folks about what they need. And he also goes out and sits down with family members without telling folks he's going to do that, to find out what are the supports and services they need and what's really working in our system. So I say that because you won't hear from him, but I want you to understand is that we have and we're fortunate to have a division director that cares about people, understands that the only way you're going to figure out how to make this system better is to interact with the people. And frankly, Steve knows that we're not been very happy with some of the decisions that have come out of the department over the past year. And he's still willing to be here. That was a good thing. He offered, so that's great. And we want to have an opportunity to hear what he says, but a great chance for you to ask questions. And Steve's told me he was willing to spend some time after talking to folks if we don't get them all done with you. So join me in welcoming Steve Jordan to our conference.
Thank y'all very much for the opportunity to come here. And I appreciate anybody being here today after the rain that you had to get through, or the swimming that you may have had to do to get here. Kind of what I want to do today is give you, as the moniker says, an update on state services. And want to start kind of going through with being able to make this work. There we go. Okay, how about back up? Okay. Kind of want to get started talking about the legislation that was passed this year, talk about the budget, the different mergers that are going on from the LME perspective, the BC waiver expansion, that little thing you may or may not have heard of, and the CAP MR waiver renewal. I know that that's got a lot of folks with a lot of questions. And I'm a son of a Baptist preacher, so I tend to get long-winded from time to time. I'm going to try to keep this to about 45 minutes of what I'm doing here, and then I want to hear some questions from you, which I know is just going to be very difficult for y'all to have any questions to ask from that. But no, I truly want to hear what you have and what issues you may be dealing with. Well, start with the legislation. The first one was Senate Bill 316, which kind of was referenced as the free PBH legislation. What that allowed them to do is, in the previous year, it had been said that we could not expand the BC waiver beyond the two sites that we had chosen, which was Mecklenburg and Western Highlands, and that PBH could not expand outside of its borders. So that legislation kind of took care of that. What it also did is it set up a better explanation of when area authorities separate what the fund balance distribution process needed to be, because we had anticipated that mergers were coming. The next one was House Bill 916, which was the bill that I think some of you actually came to Raleigh to speak on and may or may not have gotten to do so. It talks about managed care expansion. One of the things that your representation, Dave, helped to get into that was that 15% of the profits that are generated through managed care have to go back into DD services. That's a pretty big deal. And from your end, it was a pretty big win. And it was reached because we needed to know and we wanted to have support in doing this. And the other thing being, the big fear that you all have and others have is that the transfer of services from that mental health money is going to go to you to do DD services, but more from your perspective, that DD savings are going to run into expansion of mental health and substance abuse services. So this is an earmark kind of thing there. The other one was, how are going to case management going to care coordination? The community guides. That was because care coordination is there to replace targeted case management in that. And we also gave the point for minimum populations for LMEs. Currently, they serve 200. They have to have 200,000 population to form an LME, but I'll talk about that later. The next one is Senate Bill 437. That was affecting us at Mental Health in regards to First Evaluators Program for folks with, in determining involuntary commitments for folks with mental illness. Come on. Oh, I hit the shift button. Senate Bill 578. What that does is it transfers state psych bids. What it allows is the Secretary to kind of forego the CON process, and we are in need of more psych beds through the in the community, and it allows the Secretary to issue those beds to folks who want to expand. The next is House Bill 677. That's where DSS, DMH, and have to work with the adult care homes on transfers. What that is in the adult care home area that we are right now with the issues that we're having with the Department of Justice and with Medicaid, there's a fear that folks had that there was going to be a mass discharge of folks with developmental disabilities and mental illness that are in adult care homes for that. So there is a transfer panel, and basically the way it works is that mental health and social services will get involved at the point that the adult care home has not been able to secure an appropriate placement for someone upon discharge. House Bill 618. That is the one that folks were working on, and we already had a task force going in regards to that on basically the duplication of functions that different departments have, where licensure through DHSR and monitoring through mental health and DD and substance abuse and Medicaid will all come out to you, look at the same thing, and probably the most important thing that drives folks crazy is have 3 separate opinions on what they just looked at. In true government fashion, we put together 2 work groups to look at duplication. You can't make this stuff up. But anyway, my boss, Dr. Beth Melcher, is heading up the one that we were a part of, and we had folks from the community sitting around, and it's just amazing, you know, what it is. And I would joke with folks from my time as a provider that just the use of the film tool that they come out and monitor agency with, we got our 3-year certification in film 3 years in a row. They were supposed to come back in 3 years, and they came every year to give me my 3-year approval. Those are the kind of things that, you know, there's a reason somebody's continuing to do it. So we tried to attack the reason and look at that. The other part that was really big about this, and as I drove my work group on duplication, was don't tell me what you don't like about the system as we have, because we can take a part off here or take a part off there, and at the end of the day we took a bunch of parts off, but it may not be a workable structure. So we started looking at what is it that works. And more importantly, we kind of got driven to where is it that we're going. And where we're going is to the 1915B waivers and the 916 legislation talks about the replication or the fidelity to the PBH model. You can say a lot of things about, you know, what you may or may not like from a PBH perspective. Their process is a whole lot more streamlined than is the 3 divisions of state government that you have to deal with. So we started looking at what is it that we need to do to start transitioning to that. Between now and the short session that will be coming up in May, our work group will be issuing a report to the Secretary so that he can issue some requests on things that we may need to get changed. The other thing that came out of that was, I think it was, this was through the provider association called Benchmarks. They had gotten access to a company that had a database that you could load all of your information into, and so when an audit was coming, you hit the button and all of the stuff that you had just prepared 2 weeks ago for the last audit that you got would be available at that point. One of the issues that we're running into is it would have to be a voluntary thing, and some providers are a little bit reluctant to put all of their information on maybe a competitor's server. So we're still trying to work with that one and see what we can do. Budget. We did better than most, but we still got hit hard. And let me tell you, as kind of a lead into this, we are no longer in an environment where we have limited resources. We are in an environment where we have dwindling resources. The financial picture for the state, we started out it grew every day, but I think it ended at $1.6 billion with a B short in our receipts. That's how much, and with the not rolling over the sales tax, $1.6 billion was taken out of the system. Close to $500 million of that was at the Department of Health and Human Services, of which we are associated. We got a $25 million cut. That was a cut that had to be offset by the local management entities taking their share of that out of their fund balance and spending it on services. Back probably the middle of August, we issued to the LMEs what their portion was and how we were handling that situation and what their share of the $25 million would be. Oh, thought that was me.
I know.
Okay.
I put it on silent.
Everybody else did hear that. I am okay, right? I am a bit nervous. But no, the $20 million reduction. This was a separate line item in the budget, and what it required was for the LMEs to take out of their fund balance yet again $20 million. On the first one, I had the authority as division director and through the auspice of the secretary to instruct them what to take out and how much. On the $20 million, I was to encourage them to take it out. I have no authority to make them do it. So what we're in the process of doing with the LMEs is, I think by the end of October, they're to get to us, no, the end of September, they're to get to us a plan on what they're going to do. Are they going to cover their portion of the $20 million because we deallocated the money? Are they going to cover their portion of the $20 million or are they not? And if they are, how are they going to distribute it? If they're not, why not? You know, you may or may not have this chunk of money sitting over here, and why are you not going to use it for that? Now, some of it is because of the need for capital to do the transfer, or excuse me, the 1915B waiver, but other things like that. The next thing is, from a Medicaid perspective, there's a looming 2% reduction in Medicaid services. And every month that goes where the cut has not been established makes that grow, because right now we were about to end September, so you've got July, August, and September in the state fiscal year. You now have to get that 12 months worth of cut out of 9 months. So that 2% moves closer to 2.7, 2.8%. And if you were to take it all the way to January before you administered it, it would be a 4 to 4.5% cut at that point. So we need to make the decisions that we need to make very quickly. One of the reasons that we've been slow to do that is that there were some cost savings that were supposed to come in the budget, and we're kind of having to the end of September to see where those are going. Provider assessment. I can say this because we're not in Raleigh, and you can't say the T word, which is tax, but this is a provider tax. And what it allows you to do as a provider, and we did this in the ICFs that I used to manage while I was at ResCare. We would send $3, pay a $3 tax. It would be used as Medicaid match, and that would come back to us as $9 worth of service because of the federal match. So it allows you to maximize revenue, and it allows you to, in these times, to offset cuts that are coming. We were looking at doing that on CAP MR services, but it's kind of tricky when you do it with periodic services. It's very easy to do with residential services because it's head in the bed. You have to provide the tax, and from a CAP standpoint, you would have to figure out a way to do it based on units, and 15-minute units is a whole lot to track to see how much of a check you need to write to the state government this week to pay your tax so that you can get your revenue next month. There is a desire to put CABAs in there. The issue that comes with CABAs, as we were researching this, is a lot of your substance abuse providers Medicaid is not the biggest piece of their business. The state funding and substance abuse block grant is where they get the majority of their funding. But if we include CABA, it's everybody, and you're almost going to have somebody paying a tax with nothing coming back. And that because you have to tax all services under that umbrella. So those are some of the bugs that folks are working out. The other is the hospitals have a provider tax that we're getting ready to implement, and this was their request. And what this was done, it was offset by a cut. The doctors took a cut, but the hospitals were going to be taxed so that more money would be there. And all of them got together, and this was something that they all wanted. I don't understand the particulars of the way that worked. The next, we had a $7 million management reduction at the division. This was not as much of a cut that we lost. It was $7 million was about to come back to us that didn't come back to us. And kind of an interesting thing is, as we got through the budget as the House and Senate had passed it, the governor and her folks sat me down in a meeting and said, "Tell me what this $7 million management reduction means to you." And I said, "It means I'm not getting money that I wasn't counting on getting." And they go, "No, no, no, that isn't what opportunities are lost in that." And I had to be very honest and say, I never thought it was coming. So the opportunity that was lost, we never anticipated. But the kind of things that we would have lost are from the Mercer report that was out about this time last year on our preparation for getting ready to be a division that manages maybe as many as 12 separate managed care organizations. So that was an opportunity lost at that point. There was a $5 million elimination of IT reserve. How that affects us is, again, through the managed care process. IT and data becomes, one of the lifebloods that runs through your veins, and our opportunity was lost for that. CCNC was put forth, and they were required to have $90 million in savings. That comes out to, you know, $15 million every 3 months that they have to save. We, between now and the end of September, have to go and the department will have to look and see where we are on pace for that. And depending on that pace, we may have to take, if they may have any savings, we may have to take another $90 million out of the Health and Human Services budget, of which we are a part. And we are a very big part. So that's why I talk about dwindling resources as opposed to limited resources. There's another thing that was in there based on the managed care transition of Western Highlands and ECBH coming on. There's a $10 million Medicaid savings for behavioral health that is over there that, again, if they don't come online and they're not as productive as we thought they are, it's an additional cut or a piece of management that we have to make. The last number I got was from Deputy Secretary Watson, was even if everything hits the way that we think it will, we will still fall about $100 million short of our budget for the year. You know, that's real money. That's a lot of services. I mean, that's services for aging, that's public health, and DSS services, and our services. So there's a lot of things going on. And the reason I tell you this is not to be a buzzkill and just kill any happiness you have here is this. What, that may be more real than it needed to be. The point being is, this is the environment we're in, and just because there weren't cuts that came in the budget, there were savings, which is a cut by a different name, that you have to produce. Because if you ain't earning, you're dying, and if you ain't saving, it ain't coming. God, y'all need to be impressed with my education. I was educated in South Carolina. LME mergers. This 122C-115, Section A, for those of you who want to go back and read it, is where the population limits change. Right now, it's at 200,000 to be an LME. It moves to 300,000 starting in July, and July 2013, an LME's minimum size has to be 500,000. Now, this was probably one of the more interesting things that happened in the budget. As a provider, I've sat around tables going, we got too many LMEs and they're inefficient. You know, we used to sit and dream of, okay, what would it do and how would they configure? There was this whole battle that we had over LMEs need to be contiguous. And even legislation that came in last year and said they had to be contiguous. This right here did something that people have been wanting to have done for 10 years, and that is LME consolidation. One of the natural things that kind of came out of it, with the exception of the single counties and PBH and their merger with OPC 5 County and Alamance-Caswell, contiguous is pretty much how they chose to line themselves up. And they did it not because the division or the department was beating on their head telling them, you got to do it. They did it because it was the logical next step for moving forward with what they have to do. Now, with this comes some issues that we're going to have to deal with come May, and that is over governance. Because when you make LMEs this big, ECBH is 19 counties. That's huge. One of the things that we've promised is continued local representation. How are we going to achieve that? Well, we can't keep that with our current government structure. Even the boards are coming to us, the mental health or the LME boards are coming to us and going, this is huge. So we're going to be working with folks between now and May to come up with some kind of governance structure. And I'm not saying this to be sarcastic about Dave or anything, but Dave's got opinions. about how it needs to be done. I've got opinions about how it needs to be done. You know, Bob Hedrick has opinions, Peyton Maynard, Karen McLeod, all of those who represent folks. CFACs have opinions on how it needs to be done. You know, the ARC, individual local ARCs have an opinion on how it needs to be done. So this is not something for us to rush into. Because what we're doing, we're saying, is going to have impact for 15 to 20 years down the road. We better put a whole lot of thought into something that we're planning on lasting that long. The next thing, how did the merger start shaking out? Well, this was kind of a late entry because Guilford had initially sided themselves with Durham, Johnston, and Cumberland, single counties, and then decided that it would be in their best interest to merge with Sand Hills. So they are in the process of doing that, and I think they're on track to either have it done by July of this year or either January of this year, because also part of the legislative information that I didn't put up here was that they no longer have to seal a merger on July 1 of a fiscal year. They can do it throughout the year. More likely they would choose to do it at the end of a quarter. East Point, Beacon, and SER are forming. This is an interesting kind of dilemma that they have. Neither one of them meet the 300,000 alone. So somebody will have to merge with somebody between now and June, or part of the penalty for not being there is we remove administrative money from their budgets. Because, and it isn't that it's arbitrary, what we do is we pay them their management fee based on the number of people in their county. We now say if you're at 200,000, we're going to pay you and spread that money across 300,000, and it drops substantially at that point. Pathways, Mental Health Partners, and Crossroads, they had already been talking for about 18 months before this happened, and they are telling us they are fully prepared to be merged by July of next year. Southeastern Center and Onslow Carteret are in the merger process. The interesting part for them is that Southeastern is in the reapplication phase for the 1915B, so if their application does not fit, they will have to go looking for a partner to merge with at that point. And then PBH in their merger with 5 county, Alamance, Castle, and OPC. That is part of the process, and that was something that they've wanted to do for quite some time. And when the availability came, all of the parties got together and thought that this was something that they wanted to continue doing. 1915B waiver. The folks that are still in application, and their applications are due back to us on October 1, are Wake, Centerpoint, and Southeastern. Durham met minimum standards, and they are in a plan of correction process for this, and their application I think has already been turned back into us, their plan of correction, so they're ahead of the plan. But these are the folks who are still in that process. Durham represents more than just Durham in this. Durham represents the configuration that they've chosen to put together, which is Durham, Johnston, and Cumberland counties. They are all single county run mental health centers, and just from just political structure, it makes those a little bit of a different animal to do the BC waivers than does a multiple county LME. So they have chosen to get together through what is called an interlocal agreement and work with each other through that. Like I said, Southeastern represents Onslow Carteret also, and Wake, they've been having county council meetings and county commissioner meetings to get their application ready with the proper structure, and I think they had a different animal altogether. They were a combined Health and Human Services division, and they had to go through and pull mental health out and have it form as a separate group. So a lot of things that have to take place in this. Rollout day. Western Highlands is slotted to come on July is not the first month. January of 2012. I think the effective date is January 3rd of 2012 because that's when folks come back to work. ECBH will be coming on in 04 or April of 2012. And Smoky and Sandhills will be coming on next summer in July. And then Pathways, East Point, and Mecklenburg will be coming on in January of 2013. I didn't put the other ones up here that are in application, but if their applications are successful and accepted, we will have 7 managed care entities starting up on January 1 of 2013. And as Dave and his folks have been talking to me, and they're right, that's a different transition than the onesies and twosies that we have coming on in January of this year and July of next year. It's because you're moving a whole lot of people. And if you think about it, you got Wake, you got Met, you got Winston-Salem. You've got 3 of your top 5 population centers that you're doing at that point in time. And really the majority of the population that you're dealing with in this managed care transfer is going to be happening on that day. Whether the applicants are successful or not, those counties have to be transitioned at or by that time. And now probably what you came here to hear, and that's the CAP-MR changes. The CAP-MR changes are no services may be provided to a minor child by their parent or step-parent. That is a change. Personal care and home and community supports may be provided by parents who reside with the adult participant. And parents or other individuals residing with adult participants in their natural home may provide up to 40 hours a week of approved medically necessary service. Let me tell you where we started. I was over there talking to you about the budget cuts and the savings that we have to generate and how they're cut. When I got here last year, the CAP program was on a run rate to be overspent by $31 million. I probably did myself a disservice by not making that a public issue through utilization, and really it was when CAP slots kind of got emptied that they weren't aggressively sent to be filled and other things like that. We were able to take, and really one of the big things that we did, and see Trish back here, we probably made her job impossible to do. She's with Money Follows the Person. That program got slowed down on doing that because folks probably, well, more than probably, folks didn't understand the advantage that that would give us in this. But anyway, we ended the year at $4.5 million over budget. We spend $400 million a year in CAP-MR services. What that equates down to is we took, well, we were $31 million over budget, which puts you at about 7 to 8%, and we were able to move that down to where we were only 1% off. Well, what we have to do now is, where we are, is maintain the level of what we're doing. And that is where that is where some of the changes are coming from the financial end. Part of the CAP-MR changes are from a personal care standpoint, from MRPC and SNAP for folks. The SNAP score will be equating to the number of PC hours that someone's eligible for.
Can you go back a slide?
Yes, I can. Given the budget situation, it'll be $5.
Dave said he has it in his list.
Well, Dave's got me a mug over there that he said was less than $5. So. This will be on the computer, and there'll be the availability to mail this out to folks. And if any of you are going to the trainings that are currently going on, these are slides that I didn't write. I just stole from Sandy's presentation. I guess it's not plagiarism since I just admitted to it, is it? But no, just for consistency, I wanted to make sure that I was getting the same thing too. Is that okay? You got it? These, and I understand the controversy, and where personal care is, Dave mentioned that I went to a home of a 45-year-old man that was receiving services, and his mother is who he lives with, and she's 65 years old. It was quite an experience. If I'd gotten there 5 minutes earlier, I would have gotten to help bathe him. This is a mother that was going to give me the experience of my life of knowing what it was like to have a son with developmental disabilities and what she had. I told Dave that whenever I left there, it was probably the only day in the past year that I hated my job, not from the standpoint of what I saw. What I hated about it was, as a private provider, I could probably fix this in 45 minutes. I mean, it was so simple, and it's not her fault. My belief walking out of there is that service providers, well, number one, her case manager had her spread out over 5 different agencies for services. And there was an inconsistent nature of people showing up for services. So she may have respite coming for the weekend, at the last minute they call her and tell her, I'm not coming. The agency doesn't even have the guts to call her. They have the worker call. Then she has to call the on-call system and hopefully track somebody down for them to only tell you, we weren't planning on this either, we don't have anybody for you, I'm sorry, your weekend plans are gone. Kind of my view of this is this. If that had been a patient on chemotherapy, there isn't a provider around that would have denied that person what their medical right was to have. So, and as a person who used to provide the services and knowing you can do it better than this, I left there with that. The other thing I left with was an understanding of just the amount of personal assistance that he requires because of his inability to walk, his inability to communicate, and just the deficits that he has from the intellectual disability and the physical disabilities that he has. We, for her, have created a jail or a one-person institution. She can't leave. She can't go. When I met her, she's 65 years old. And I was very bold in asking her a question. I said, okay, you're 65, you're not going to be around forever. What are your plans? You know, what are we doing to plan so that he is taken care of? And she said, Steve, my prayer is that I die before he does, or excuse me, that he dies before I do. That's a hopeless place to be. But the hope is not there because today there is nothing that gives her any indication that life is going to be any different tomorrow. That her situation is going to be any different tomorrow than it is today. She loves her son. She's not there out of obligation. She's out of there because she loves him. And she truly believes, like I do about my kids, they may not believe this, but I believe that nobody loves them or can take care of them as well as I can. Now, given the discipline that has to go out to my kids, sometimes they would think, yes, somebody else could love me better at this moment than you do. Or at least differently. But it's that connection, and that's where services are real, and we are having a negative impact on our life. And I didn't get involved in this business to make it worse. The desire is to make it better. I say that with the bad news that comes and the way people feel about the CAP services. Some of these are necessary things that we have to do. Some of them are things that we missed the mark on. But this is kind of where we are with this. Did everybody get this part? God, that was a long ramble I went on. I apologize. More changes. Habilitative services are limited to 129 hours a month. That equates from 40 hours a week of service down to 30 hours a week of service. Based on a 7-day week of services being provided, it really comes out to at or around 30 to 45 minutes a day of a service cut. I know this is math, I know that it's theory, but that has somebody coming in 20 minutes late and leaving 20 minutes early. I understand that's not the way that the world works, because there's definite things that have to go on in there. The other is hours do not roll over from month to month. This isn't singular wireless where you have rollover minutes or rollover hours. But that's, I was surprised to find out that if that was even something that was being allowed at this point in time, because kind of in the world that I had lived back in the days of CBS, if you didn't use it that week, you couldn't go back and do it because there were caps and maxes on it. Children attending school may receive only 20 hours a week. This kind of came down to the CAP MR services are not a substitute for education in school. On school days, children may receive a maximum of 3 hours a day of habilitation, and there is justification to exceed this limit. The next one is, doesn't apply to adults participating in continuing ed classes, which means that they're not limited to the 3 hours a day. Respite can no longer be billed on the same day as residential supports. This is not a problem in group homes. This is a problem in folks in AFLs. And one of the issues that I think this was meant to go at, a lot of this stuff was written or designed before I got there. That's not an excuse. But I think this was, there's some folks providing AFLs that are nothing more than small group homes. They may have 3 individuals living with them. The day program takes them outside the house for the day. They work a job, they come back and they work with the individuals in the evenings. I think if that's what folks are wanting to deal with, because residential supports is a daily service and long-term respite is that, and you're already paying for the time with that, is that. Nursing respite will not be available as services under 2011 CAP IDD waiver. That moves over to the medical surgical piece of Medicaid. Staff must satisfactory complete requirements under participants' specific training. If there are requirements that an individual has, the person working with them must be trained in those specific things. If someone has a G-tube or a trach, there has to be specific training on the monitoring and the care of that G-tube and trach, whether they're doing it or not. Because if you're with them, it comes with you. You need to be able to observe whether things are going well or not with that. Home supports will not be included as a service in the new waiver, but the parent is allowed to work in either home and community supports or personal care services for up to 40 hours a week. Part of the intent of this was home supports was twofold. Number one, some folks were using home supports as self-direction. The other part being folks were being, parents were just being, like the lady I went and met with, folks being killed with just, oh, that's part of your home supports, you need to do it. And they were working 80, 90, the stat was in there, hours a week with that. Creation of situations similar to one-person group homes is what we had, because there was the trapping there, because if the other services didn't show, it was there and the people couldn't get out. We've got to change that one. What providing the service in the spirit of the waiver, that's what I'm talking about as the self-direction. I didn't put this in small print because I didn't want you to read it. But anyway, all continued need reviews that exceed 129 hours a month for rehabilitation services that meet medical necessity will be approved through October 31 of 2011. And the new limits for adults will go into effect November 1st, 2011. The reason for this is we're ending one and starting another one. So we can't approve services that may not be in existence, or the limitations are there. And one of the pieces of confusion that people are having is, okay, I should be able to start appealing. The appeal rights will begin on 11/1 when the waiver goes into place. A request to exceed the limit for children under age 21 must be submitted. A request to exceed 129 hours a month for children under 21 years of age will be reviewed, and if EPSDT, I wish I could remember what EPSDT is, but anyway, it's, I think, evaluation planning. There you go. I'm lucky I've got the letters in the right order up here with that. But anyway, that is a program for children which says if it doesn't exist and they need it, you still got to pay for it. And it would be evaluated through that.
Steve, are you saying there will be appeal rights for that 129?
No, what I was saying is if there are appeals that folks are going to be eligible to do, that's why folks would be able to appeal, is that the waiver does not go into effect until November 1. Therefore, theoretically, you've not been denied anything if it doesn't exist yet. It's probably one of those lawyer arguments. The new waiver is effective, and it allows for a maximum of 129 hours of rehabilitation a month. This is a firm limit for adults over 21. Requests to exceed the limit for children under 21 will be received and evaluated under EPSDT. With that, how did I do? Okay, did it in under 45 minutes. So with that, I'm sure folks have questions. What I'll ask you to do, and this is just more for formality than anything else, because I don't expect that you would be this way, but, you know, I want to deal with your issues and your concerns. It gets very difficult if it becomes personal attacks on me or somebody else at that point. But no. So, I'm more than willing, and like Dave said, I've got a 4 o'clock phone call that I have to do, but after that, I'm available, and I'll hunt you down, but I'm available to talk to anybody individually as long as you want. So, Dave,